So certainly I have seen patients where I've told them, based on my ultrasound scan, there's really nothing I can do to help them. And for patients that travel from interstate and overseas, I'm seeing them the day before, we tell them that if I can't do the surgery based on my initial assessment, then we'll give them all their money back. There's no point going in and doing surgery where you know already with the ultrasound there's nothing you can offer the patients. And certain circumstances would be where they've had very serious damage to all of the epididymis through aspiration, needling with failed IVF. I've had a patient who had 12 separate extraction procedures where his partner had 20 IVF goes. I mean, those patients are really tough. In fact, in that case, it was interesting. We could actually do a reversal on that patient. He had a failed vasectomy reversal 10 years earlier. He had a litre of hemorrhage of blood after the vasectomy reversal. That put them on to IVF. She had to have 20 IVF rounds, and he had 12 separate extraction procedures. And she was 45 when I saw them. He was 69, very fit and healthy builder. And in actual fact, I refused to do the surgery because I thought it was going to be unnecessary. But I got an 8-page letter from the patient wanting me to do the surgery. She told me that her gynecologist suggested that they couldn't help anymore, that she had really good egg count, and they should proceed with the vasectomy reversal. I consulted with my local professor of IVF here on the Gold Coast. I also conferred with Professor Owen and Dr. Silver from overseas, and everyone was telling me to do the surgery, and we did actually end up doing the surgery. And at 46 she got pregnant, where 10 months after his reversal he had a fantastic sperm count. Unfortunately she's miscarried, and we're hoping she would still have a chance of having a natural conception. I've seen patients where women, clearly the limitation will be the age of the female partner, where they have concerns about their egg counts, and their fertility tests tend to suggest that they may not be fertile anymore. It's silly doing a reversal in that case. I've reviewed surgery on patients where I can clearly see that their pain syndrome has not got anything to do with something that I can surgically repair, in which case they need to have other modalities of treatment. I've refused surgery where patients have had a vasectomy and they are of the feeling that their sex life hasn't been as good because they've got maybe some impotence that follows. I tell them that their impotence isn't from their vasectomy, and that they need to speak to the doctor who did the vasectomy to refer them to a clinic to assess them for impotence. So there's certainly a vasectomy reversal isn't a fix for everything, and certainly it's a case-by-case approach to effect the best approach. But certainly the ultrasound's been a very powerful tool for me to be able to provide the best possible procedure, to do microsurgery, and even the most complex microsurgery. And we have cases where we've hit it out of the park where others have failed, but certainly it's not a solution for every single problem that presents. And rather than just a little examination with the fingers, we have the very powerful modality combined with very specialised reversal techniques to get great results, but certainly it's not for everyone. So just tell patients after our consultation that they should do their research, do more reading, look at their options of IVF again, and then certainly if they decide to have a vasectomy reversal, I tell them that they should be absolutely certain about every element of the surgery. Just because someone tells them they'll do microsurgery, patients need to understand there's no such thing as a microsurgical university. Most people will do a fellowship training if they're going to do reversals, and they will learn from their mentors. They were trained by their mentors, and so on and so on. So from my point of view, I was trained by the pioneer of microsurgery. It was his way or no way, and I tell patients to be very specific about their questions, even the needle that's used. Does the sperm get tested during the procedure? Is it possible to view the video and the technique that they do? Because obviously technique's very important for success rates. To see if it's done as a 3-layer closure or just a few 1-layer sutures. Is there unnecessary undue tension on the vas joint, and what other techniques are used to assess the scrotum at the time of the procedure? And certainly there are no textbooks and journal articles that talk about the use of ultrasounds. That's my personal work, but that's accumulation of over several thousand ultrasound scans of vasectomized males. And Professor Owen, when he was working with me for 10 years, he could not believe how invaluable that tool was. So I will never ever do a patient's reversal unless I've already done a map. And I tell patients to use our information to get as much information as they can from others as a second opinion.